Testing, testing. Good morning, everyone. Can you settle in so we can go ahead and get started here? Pretty much want to keep on track today because we have a full day. Okay, folks, welcome to day 2 of the convention. Hope everybody enjoyed the program yesterday. And for those of you who participated in the tour, I hope you had a good time looking at the sights and sounds of Nashville. Just a few housekeeping items we want to take care of very quickly before we begin the program. We'll start the day together as a group for the first 2 morning sessions. Then we'll break for lunch. You'll have an opportunity to pick up a box lunch, enjoy that, and then when we reconvene, and I'm certain we'll have a bell or something, let you know. When we reconvene, we'll have a couple of breakout sessions, and certainly maybe take a look and identify which one of the breakout sessions that you want to go to, and take advantage of those. Now, to begin this morning session, the power of the patient voice, the kidney community moves to engage. This is really what we're all about here, is giving the patients an opportunity. We represent your voice. We're you, and we want to just get some information out there so we can have a better idea. What does that really mean? You've heard the term patient-centered care, but what does that really mean? Essentially, it's when a patient is put first in every healthcare decision that affects you. The care and the patient is also actively engaged in the care himself. Yesterday, you heard a young lady, Dory, mention that there's something called conditions of coverage, and you have certain rights in a facility. That sounds nice, but when somebody's hovering over you with a needle, that's not the time. So having a discussion today will give you some ideas, let you know some of the things we're doing, and hopefully arm you with some additional information where you can really make certain that patient-centered care is in effect where you are. And one of the things I want to say that we're helping to lead the way. We work with trusted partners from groups like Center for Medicare, Medicaid, Food and Drug Administration, industry sponsors like many of the individuals, the companies that were here yesterday, which you saw. And today, we're going to hear from the American Board of Internal Medicine, ABIM, very interesting role that they play with patients like us. As a matter of fact, I think they had a focus group to zero in on some questions to see what patients think about some of the things that they're doing and get their input, which is very important. And we also have my good friend and colleague over here, Maggie, from the Kidney Patient Advisory Coalition. Just thinking about a couple of yesterday's sessions, one that was led by Steve, Dr. Fadum, Dr. Hakeem, the kidney community is now in looking for the patient for guidance on what's important. What are your thoughts? What are your challenges? So that we can overcome them. Overall, the kidney community is unifying and trying to provide the best care and quality of life for patients. So what I'd like to do is take a second, introduce my colleagues, the other panelists. I'll take a few minutes to go through some slides, and then we will sit down, listen to him, and hopefully we have enough time at the end to have some questions and answers. But I do want to say this, that we will be here for a while, so in the event you're not able to get your questions answered as we end the session up, because we are trying to keep on track. I laugh because that's tough to do, but we're going to try to keep on track. You can have a chance to talk with us, or certainly them, to get any of your questions answered. Okay, first we have Dr. Talat Ikizler, and he's a practicing nephrologist here in Nashville, part of that Vanderbilt connection. Thank you. He specializes in internal medicine and currently practices at Vanderbilt Medical Center and medical nephrology and hypertension. Dr. Ikizler is the chair of the Nephrology Board Exam Committee for the American Board of Internal Medicine. He's joining us today to share how ABIM is utilizing patient input in the redesign of their nephrology credential program. Then we have Maggie Carey. She's the chair of the Kidney Patient Advisory Council for the Forum of ESRD Networks, End-Stage Renal Disease Networks. We all know that there's about 18 of them throughout the country, and she's the chair of the forum, which represents all of them. And KPAC is a dynamic group of patients that help the network respond to patient needs and seek ways to improve panel staff relationships. Maggie's joining us today, all the way from the West Coast, to share the important work that the council is doing and to incorporate patients in various aspects of the ESRD network projects. And Maggie's certainly a good friend. We spent some time together on one of those technical advisory panels, so we're excited to have both of you with us today. And I'll go ahead and start it off by making a few remarks and let you know some of the things that AAKP is doing to promote the patient voice. Then I'll quickly turn it over to my colleagues here because I certainly want to hear from them. Want to emphasize, your voice determines the future of your health outcomes. But first, a commercial. This is my donor. This is one of the reasons why I do what I do for AAKP. I never sign up with UNOS. In Washington, D.C., I looked at the numbers, didn't feel too good about that. So as I went out, educated people about what being on dialysis meant, I was with the Chamber of Commerce, and I talked with some colleagues there, and I've talked with you now more than I ever talked with her. She walked up to me one day and said that she would give me a kidney. Just blew me away. But we all know you have to go through the testing and everything. And I think it was about 8 months later, after she had to change jobs and everything, and wait to be there. But I always want to acknowledge her because I wouldn't be here in the condition that I'm in without her just being so thoughtless and doing that for me. Now, yesterday, we put this slide up, but we are an evolving organization. What do? AAKP, we educate, we advocate. Last night at our board meeting, we decided to add patient engagement to our mission. That's why it's in green there. So again, that's something that we want to certainly take a lead role in promoting that. Big picture healthcare stakeholders, just want you to glance at this, not going to spend a lot of time on it. But these are the stakeholders and organizations that we are dealing with. And note down at the bottom that the patients have a disproportionate impact. Whenever we go on Capitol Hill with the doctors, they want the patients there with them because we have a different level of credibility. Patient voice is sought after. In all these areas, patient engagement, patient-centered care, one that's near and dear to my heart, disparities in healthcare for kidney patients. PCORI stands for the Patient-Centered Outcomes Research Institute. We will hear from tomorrow. PROs, you know, we are into acronyms in this business, so I always like to say it out. So forgive me if I take a couple extra seconds to do that. Patient preferences, patient preference analysis, and then down at the bottom, this is very important. Patients determine the quality of life. There have been several studies about what doctors think are the most important things to patients. Then you do a study by the patients. We may think different things are important as quality of life. And I've always liked to emphasize that you determine what's important for your quality of life. One of the things that we do to include your excuse me, patient voice is, this is an example. We send out action alerts. I know you get them all the time. You say, I don't want to do that. But that's our mechanism to alert you to something that we're doing. This one happens to be, surprise, for a survey that I'm doing. And it's to get your input about how you use patient portals. What's important to you? Why do you use them? Is yours sufficient? Is it okay? Can you understand it? Do you have any training on it? These are all the questions that we're asking. So as I sit on one of these, let me see, this Health Information Technology Task Force for NRAAESRD, one of those groups. But quite frankly, when they came out with the High Tech Act, dialysis facilities weren't included in it. So we have the opportunity to have input into the implementation of that. And that's a lot of Washington, D.C. gibberish, but the point is that this is a way for you to tell me what to tell them based on what you think, not what I think, what you think. So this is a survey, and you may see this floating around if you're out there on Twitter. Is that right, Tasia? All right, he's the man, he put it out there for me. Thank you very much. This morning, so if you see it, take about 5 or 10 minutes, actually it takes 12, and fill it out. We would appreciate your input. This is just to kind of give you perspective. You see there's roughly 100, and this is, I think, a month or two old, roughly 130,000 registered people for transplants, and out of that, 107,000 of them are for kidneys. Active versus inactive. Active means that you need to lose some weight, you need to get your diabetes under control, maybe there's some other comorbidity issues you need to deal with, but the point is that they only do about 17,000 transplants a year. So we want to have some input in what happens, and this is our way of, through this mechanism and through your feedback to us, so that we can let people know what we want to happen. The other thing that's very important is research. You know, we spend roughly $32 billion a year on ESRD, end-stage renal disease, and the whole budget for NIH, National Institute of Health, is $33 billion. One of the things we look at is, you know, we might need to make some more investments in research. And what is that? The groups that we're talking yesterday. They're doing a lot of research. Want to make certain that we fund them because, yes, dialysis is life-saving, but can we avoid it? Can we catch it earlier? I'm one that went on dialysis from the emergency room, along with 62% of the other patients on dialysis. That's why we emphasize early detection. I didn't have a choice. I want to make certain that those who come behind me have a choice. Number there, $29 per patient in research versus $2,900 for HIV, AIDS, and what's the other one I can barely see? For cancer. And certainly, but the point is that we need more money invested in research, and that's one of the areas that we focus when we talk with folks on Capitol Hill. And of course, the federal government, these are places that we've been, areas that we've talked to. We will continue to pursue them. I'm not going to spend time on that. Just know that we're out there talking to the agencies that have impact. Very interesting. We have Department of Defense down there. What's the Department of Defense got to do with healthcare? Well, the initial funding for the company, Hemocyte, came from DARPA under the Department of Defense. There's a lot of things that do to take care of veterans and other individuals, and then they commercialize it. So that's an area that we need to be aware of. That's one additional source of funding for a lot of healthcare-related activities. Hey, that's a picture of myself and a young lady. We were over at the White House Organ Summit, and Melissa Goldberg there teaches over at George Washington University, but she's also the Assistant Director for Bioethics and Privacy. Now that's a heck of a title, but basically she makes certain that people don't cross the line. She was chairing the session on disparities in minorities, and I had the opportunity to give some open remarks at the session, so that was very exciting. And this young lady here, Dr. Carolyn Newland, we recognize the federal government workers that work with us. She's with the FDA. The devices that they were talking about yesterday, the cycler and the next stage next to me, all of those are devices that need to get approval by the FDA. She's the person that's responsible for making that approval. So I just want to try to connect some of the things that went on and what people are doing. And these are individuals, I mean, I had a seat next to her because she's waiting to go up and speak, so she didn't have anything to do. So I just went down and talked with her. Somebody took a picture. I appreciate that. Paul found it floating around on the internet. But we awarded her the Public Service Award last year from AAKP. and she's certainly very involved in what we do and very receptive. Okay, I'm out. We're going to bring up Maggie here next, if I can make this work right. Better you than me, huh? Here we go. Now, which one are you?
I'm that one.
Here we go. Let me get her straight. Slideshow. From the beginning. My technical skills are limited. This pushes you to the right.
Excellent. Thank you, everyone. I am just thrilled to be here. You can't imagine how thrilled I am to be here. But I want to start by knowing who I'm talking to. How many of you are patients? We got, oh my God. I don't know if I've ever been in a room with this many warriors before. That is really cool. This is exciting. How many of you are family caregivers? Family? Excellent. You guys are the unsung heroes. Without you, we wouldn't have the strength to do what we need to do when our strength wears out. And I give you full kudos for that. You don't get the appreciation, the recognition that you deserve. So bravo for all of you. And then do we have providers in here? Providers, not a whole lot. The providers I know that are here, sitting here, and in groups similar to this, I am amazed at the amount of volunteer time out of their personal lives that they donate to us that we don't even know about. These are people who care so deeply, and I give you my greatest gratitude. So thank you so much. Bravo, bravo. So anyway, on to business. I'm Maggie Carey. I'm a patient. I am the second in 4 generations with polycystic kidney disease. Do we have that going on here in the audience? We got a few. We are a group that not only inherits our disease, we pass it on. My mother dialyzed in the 80s and died as a result of a bloodstream infection. I'm currently a transplant patient, there by the grace of God. I really appreciated your showing the picture of your donor. Mine was a 17-year-old high school senior who was killed in an auto accident shortly before graduation. Her picture sits on our family wall because it's because of her that I have the strength to do what I'm doing. So, my son started dialysis about a year ago. He's 40 years old. In fact, he's probably coming off his machine in Raleigh, North Carolina right about now. And my 14-year-old granddaughter has the disease. She's the future. She's why I do what I do to a large extent. We do what we do for the future. We would love to be able to improve the present, but we need to improve the future. And I have seen changes in the last 40 years in dialysis. And you cannot imagine how uncomfortable it is for me to say I have seen stuff for 40 years. But I have. When my mother was dialyzing in the 80s, the focus was on keeping the patient alive. And they got that down. They're pretty good at that. In the 90s, when I was dialyzing, and I did in-center and I did home PD, the focus was keep the patient alive and do no harm to other bodily functions. Protect the heart, protect the bones, protect the other things that dialysis is so rough on. They got pretty good at that. If we follow the rules and take our binders and do everything else that we're supposed to. The focus now is on quality of life, and I am absolutely thrilled with that focus. And that kind of brings us to what I want to talk about today. Our topic is the power of the patient voice. I cannot stress how important it is that you let your voice be heard. We need to tell them, those that are forming policy, those that are making changes in our best interests, we need to tell them what our best interests are. There are a lot of people out there making a lot of policy and protocol with the best intentions in the world, but if we don't let our voice be heard, they're not going to know. They're not going to know what's important to us. We need to tell them how it is, what life is like in the trenches, what it's like on the machine, not just the data sheets that they're getting that are showing different, clearances in anemia management. We need to tell them what that actually means to us. We need to tell them what we need, what's important to us. Like David was saying, or Richard was saying earlier, they might think they know what would be important to them in that situation, but until they're in that situation, they can't really know. So we need to tell them what we need, and we need to tell them what we want, what our wish list is, because there are incredible innovations taking place out there, but without our direction, they could be going down the wrong path. One voice is strong. Don't ever underestimate the power of one voice. You all see that. You're all experiencing that. If you had not found your voice already, you wouldn't be here today in this room. You'd be back in your unit with your head down, trying to catch some sleep, doing whatever. You wouldn't be here participating in this. So do not underestimate the power of one voice. But a choir can bring the rafters down. And that's what we're looking to do, is shake the rafters and bring everyone up. So moving forward from this point, how many of you are familiar with the ESRD network system? Richard talked about that. We got some network people here. You know what it is. A lot of you aren't, though. So we're going to do a brief history lesson, and we will try to make it fun. In 1972, Medicare end-stage renal disease program was established. What that meant was Medicare started paying for dialysis for patients that were underinsured. If you needed dialysis prior to 1972 and you didn't have good private insurance, you were kind of up the creek without a paddle. It was not funded by the government. There were some other organizations that tried to select good candidates and give some help, but yeah, until 1972. And that wasn't that long ago. Oh my God, I remember that. In fact, I graduated then, so scary. In 1978, the network system was put in place. The network system, more or less, monitors all the dialysis units and all the transplant centers in the country to make sure that you're getting quality dialysis wherever you are. That makes sure that the dialysis you receive in Upper Maine is equivalent, meets all the requirements and protocols as the dialysis in Nashville, Tennessee, or New York City, or Anchorage, Alaska, or whatever. That's what the networks were charged to do. There have been some changes and some modifications over the time, and there are now 18 networks that cover all the states and all of the territories. So every one of you has access to a network. So kind of a little map there, tell you where they are, what they are. They're kind of more or less grouped by geography, but you've got a network, and it's there for you to use. Now, networks have a structure. They have a governing board, they have a medical review board, that's doctors, a bunch of doctors from their geographical area, and they have a patient advisory board, and I think that's where we're coming in. Each network has, I think they're mandated to have 15 patients, 13, 15, I think it's 15, on their board. They're called PACs, they're called Consumers Committee. Each network has maybe a different name for them. But this is the patient voice. These are the patients that work with the networks, that tell the networks what's important to them, that sit on all of their boards. So it's important to know that. And networks struggle to find patients who can sit on their PACs. This is not a list a mile long of patients banging on the door to get in. They need the patient voice. They need the advocates. Now, in somewhere around the 1980s, the ESRD Forum of Networks was established. This is a nonprofit volunteer group that represents all of the networks. Their mission is, and I got to read this because I won't get it right, to support and advocate on behalf of the ESRD networks and to improve the quality of care for patients with renal disease. So basically, they formed this little nonprofit group that could actually join the voice of all the networks and advocate up to the federal government level. So they have an executive committee. They have an EDAC, which takes the executive director from each of the 18 networks. And then they have the MAC, the Medical Advisory Council, which takes a nephrologist, a kidney doctor from each of the networks. And they meet and they meet a lot. I mean, they do a lot. And they're doing it on their own time. These are the ones I was talking about that are donating hours and hours and hours a week of their private, personal time to try to make our lives better. Now, about 3 years ago, they actually added another branch, and that's the Kidney Patient Advisory Council. That's what we were talking about earlier. The KPAC is a patient from each of the networks. So we cover the whole United States. There's 18 of us on a good day, and I will say we have turnover on the KPAC. In the last year, 2 of our representatives, they died. We do that. We're patients. We've had health that has struggled, that has deteriorated so that people have had to step back. We've had successes. We had 2 in the last 2 years that were able to go back to work full time, but couldn't juggle the full-time work and the advocacy. So they stepped down. So this is constantly fluctuating and fluid group. But they are a dynamic group. That's where I come in. I'm the representative from my network, and I am the chair of the KPAC. I was there when it was born. I continue to chair it, and at some point I'll step down and somebody else will step forward, and I'll have a little more time on my hands. But until then, I'm where I am doing what I'm doing. And what does the KPAC do? Because this is important to you. We do a lot. Now, I have to tell you, I live in a forest under a tree canopy, 24 miles to the nearest grocery store, and I don't have cell phone reception where I live. I am the only woman I know that doesn't have a cell phone. You know, well, I do. I do when I'm traveling, thank God, because they changed my flights twice yesterday. But I live in the middle of no place. I am Maggie from no place. But I have stepped forward and I have been in this, and the things that I'm involved in, the things I've been involved in for the last 3 years, I mean, I didn't know existed 3 years ago. As KPAC members, we sit on all of the boards for the forum. Well, we have representatives on all of the boards for the forum, and we do things. We have written or developed papers on anemia management and readmission measures, the Kidney Council Alliance Fluid Management Project. I mean, these things I didn't really know about before. We have been part of the 5-star rating program, the beneficiary grievance process, the Medicare rules for Part D prescription drugs. Do you guys know about all of this? I didn't, and we had to write papers on them. I mean, oh my God, I got in over my head on that one. We have been on, or KPAC reps have been on countless TEPS, technical expert panels. Do you guys know what those are? Have you been involved in those? They're these groups of wonderful providers, usually doctors or whatever, who are developing new protocols for us that are going to impact our lives. And recently, they've started adding patients to these groups. I mean, incredible stuff I didn't know existed. So the KPAC reps have been involved in the 5-star rating technical expert panel, comorbidities, vascular access, the ESRD emergency department, TEP. We were together on that one. Like 2 patients, they didn't stand a chance against us. The National Quality Forum, the AHQA Policy Forum, things I didn't know existed. We sit on those. We're on conference calls with them, and we have face-to-face meetings with them, and we are affecting policy. We have contributed to toolkits. How many of you know what a toolkit is? Because I didn't. A toolkit is like an owner's manual for a different something or other. It's, I don't know, 30, 40, 50 pages of instructions, for lack of a better thing, and forms and whatever. We've developed toolkits or worked on toolkits on transitions of care, on home dialysis. The KPAC, the patients themselves, developed a toolkit on, and that was just released 3 days ago. Oh my God, we are so proud of that, on the grievance process. Ooh, I'm missing. See, I never push the buttons. This was written by patients, for patients, to help other patients go through the grievance process if you have a grievance with their unit. I hope you never do, but if you do, we've got the instructions for you to how to do it. Make it a little bit simpler. We have spoken on countless events. We have done countless things. We even went to the organ donor summit that Richard talked about. I got invited to that. Oh my God, look, I'm wearing the same thing. I mean, is that cool? It's not like I have more than 3 outfits that are worth being seen in public. But what can I say? We were invited there. This was a big deal. Maggie from No Place went to the White House. I mean, how cool is that? I have got such local notoriety on that one. It's incredible. The KPAC communicates in a specific way. If there's an issue that comes up from CMS, from one of the other groups, they give it to us. We take that, go to our local networks and say, give me the information. Okay, and this says back, it should say KPAC. Sorry, I didn't check that slide. We go to our local networks, we ask the network patient councils, what do you think about this? What's important to you? What's not? How should we respond? These patients from the network go down into the units that they work with, that they have affiliation with, and they ask the people in the chairs, what's important to you? What's not? What should we respond? And then the information flows back up. It goes both ways. It is vitally important. Yeah, don't go there yet. What I can say is that CMS and the federal government is very impressed with our patient voice as ESRD patients. In fact, they're holding us up as a model for other groups, other areas to emulate, because we have been able to harness our voice. They want hospitals to do it. They want nursing homes to do it. They are saying ESRD patients have it. They have it down. Do what they're doing. Personally, I don't know if they can, because let's face it, when you get out of a hospital, you don't look back. We have ESRD. We are always going to have ESRD. We are always going to be able to do this. And for those on in-center hemodialysis, you're in a chair for what, 15 hours a week? That's downtime. They've got a captive audience that they could get into. What I'm saying here is that your voice is important, and there are things going on out there that are affecting your lives that you can be a part of. If Maggie with no cell phone can do it, you can do it. We have an incredible opportunity to shape our present and to shape my granddaughter's future. One voice. Do not underestimate the power of one voice. You all have found your voice. Think about the person in the chair next to you that hasn't, because there are a lot of patients out there that haven't found their voice, and there are ways that maybe you can engage them. In fact, that's part of what I'm speaking about this afternoon in a breakout session on making dialysis safer, is how to get that person that hasn't found their voice to find it. But you guys have that. You're there. You wouldn't be here today if you hadn't found your voice. One voice can change the world. A choir of voices, there's no stopping us. All we have to do is sing together on this. So with that, thank you.
Oops, not this one. Well, good morning, everyone. I'm very happy and honored to be here, and it's really wonderful to listen to Maggie and Richard and get motivated about this. And I will show you what I do in a few slides here. But I will tell you this, everything that they talked about are extremely important things. And I have so many things to say about those, so I'm just going to stop myself and focus on what I'm supposed to say, which is the ABIM, which is a very important component of your overall care. So why am I here? It's not because I live here. I do something that's important, relevant to ABIM and for the care of the patients. I'm actually the chair of the Internal Board of Medicine Nephrology Board Exam Committee. I've been doing that for 2 years. Actually, I've been involved with ABIM for about 8 years now. As I will explain, the first 6 years I sat in a committee of 9 people, wrote questions for the test takers, and then for the last 2 years I've been the chair, and I'm going to be chair for another 2 years, and then somebody else is going to take over. I also work at Vanderbilt University Medical Center. I've been here 23 years. I came for fellowship, got stuck. I love Nashville. No better place in the world to live. I do have an endowed chair under the name of Captain McLaughlin Hakim, and that is Dr. Hakim's unfortunately passed away wife, and I'm honored to be doing that as well. I'm the associate director of the Division of Nephrology, so I do a lot of administrative stuff. Our faculty is here. Just to let you know, we have 40+ faculty, so I do know what our physicians do quite well. And I was the medical director of the dialysis unit for about 12 years. So I do know how dialysis works. I have a good experience of what the patients feel and how they treat it. And then I also was in the medical advisory board for ESRD Network 8 here in this area for about 8 years or so. I'm the past president of the National Kidney Foundation of Tennessee. So I've got involved with that for about 10, 12 years. So I really know what you guys do and feel when you go through this process. I do a lot of clinical work, and I love to talk to the patients. I do a lot of research, so I give a lot of presentations. It's always stressful to give a talk, but nothing is as stressful as you have so many patients in front of you listening to you. I can talk to my peers, but the patients looking at me all the time like this is it adds a level of anxiety. You have to admit that. One at a time, it's okay. Anyway, so what is ABIM? ABIM stands for American Board of Internal Medicine. There are 23 other boards within the field of medicine in the United States, and ABIM is interested in internal medicine, as you would see, as you would recognize. It is a nonprofit organization which provides the credentialing or the credential of board certified to general internists, and then the general internists who subsequently take another additional subspecialty, like nephrology, kidney specialty, cardiology, heart disease, oncology, cancer. Its mission is pretty straightforward. It's to enhance the quality of healthcare by certifying internists and subspecialists, and in this case, nephrologists, who demonstrate the concept of knowledge, the skills, and the attitudes towards essential for excellent patient care. So it is for it's of the profession, but it's for the public, it's for the patients to be able to receive the most important and the best care that they can. And again, I have to tell you this, and I always talk to my patients when they come to my clinic. When we start a relationship, there has to be a trust. I bet you all trust your physicians. But I don't know if any of you have actually ever asked the question, because I've never been asked over 23 years, and I always question this. And I try to explain that, and I talk to them. Are you qualified to take care of me? I mean, are you going to be able to do? I mean, you never ask that, isn't that right? You go, you trust. That's the way it works. If you don't trust, it's not going to be a good relationship no matter what. So there has to be some sort of level of credentialing or a test or some sort of an assessment for those physicians to be able to do what they're supposed to do. And we have different things. And I think ABIM or the board certification is one of them. It's probably not the only one, but it's one of those things that really tells you, if you were to go and look at some other places I will show you, that you know that that individual has gone through this process and they're qualified to do the work. And then that's how you start your work, and then that's how you have a long-term relationship. And again, for kidney disease, this is very specific and this is very important because we have a long-term relationship. I still have patients that I care for when I was a fellow. That was 23 years ago. I still see the same patient, the first day I saw when I started clinic, who comes to my clinic still once a month. So it's a very long-term relationship, and that information, that trust is very important between us. ABIM is the largest I know of the board certifying organizations. About 1 out of 4 physicians in the United States is certified by ABIM. As I said, there are 23 other certifying boards, and there are more than 200,000 ABIM board certified physicians. And I did not know this, and I'll tell you my own personal story about this ABIM process, because I had to go through it myself. But it is a large operation. It is not a simple task to be able to really know or at least assess somebody's qualifications as a physician. It is not a black and white process. There are a lot of people who do a lot of work in the background. A lot of times these people are unrecognized and they're not known. But there's a lot of process that's going on. For the certification from the physician side, from my side, it's a voluntary process, but it's a nationally recognized standard. So pretty much every institution that I know of that has physicians, internists, or subspecialists to come and work actually requires that they're board certified. Again, I will tell you my own experience with that. It is discipline specific, so you can be nephrologist, you can be cardiologist, or you can be internist, general internist, then you have to practice in that specific discipline. It is focused on the competence and specialization beyond the medical licensure, because having a license to practice in a place, in a state, is different than being board certified. And it is independent. That's an important issue to keep in mind. It's non-governmental. So there's no pressure from anywhere else to really tell them what to do. If you're certified, what it clearly tells to some extent, although you can interpret different ways, that a doctor or the doctor that you're interacting with has the knowledge, the experience, and the skills necessary to provide the excellent high-quality care that you deserve. So that's the explanation of the determination of certification. There are multiple different certification areas. Each have a specific number of individuals that are writing the tests. There are other subspecialty boards that I'm not going to go into detail, but there's a big number of physicians that get together to do this for the whole care of the patients. And again, this is important for you because you're not only interacting with the nephrologist in this day and age. You have a cardiologist, you have an endocrinologist, you have a general internist. So all of those have to go through a different board certification to be able to take care of you. How does a doctor become certified? And I'll tell you, for me, it was a painful process. As you would know, my name is not American. I'm actually from Turkey. I did my medical school in Turkey. I did residency, internal medicine residency in Turkey, and I came here to do my fellowship to become a nephrologist. My goal was to come, learn, 2 years later go back to my country. Things worked out in different ways, so I've decided to stay. So at that time, one of those things came about that I was not able to practice nephrology unless I was board certified. My institution said you cannot do that. I was furious, as you would imagine, because that meant that I had to go through some other processes. So the way that it works in the United States, for a United States medical school graduate, you go through medical school. Again, before medical school, as you know, the physicians and most every physician has to go through an undergrad of 4 years. So this is an 8 year of education. Then you get your MD or DO degree. And then you get your residency, internal medicine, 3 years. And then you become eligible for an internal medicine primary certification. You have to pass this to be able to go ahead and get a subspecialty fellowship and be eligible for a subspecialty certification. Then you become a nephrologist. And this is the 8 plus 3, 11 plus 3, 14 years of education. So it's not an easy process. There's a lot of time and effort put into it. When I came, they said, well, you've done this, but we have to make sure that you are qualified to be able to do what you do, because we do not know the medical school that you're coming from. We do not know the qualifications of the internal medicine residency. So actually, after doing this, I had to go back and repeat my residency for another 2 years, which I believe at this time, when I go back and look, was an appropriate decision, because there are different things that happen. The care of the patients are different. I'm telling you this because I think now, as the chair, I get people frustrated who come to us and say, oh, please approve us, and we say no. I've been through it, and I know it is important for you to be able to go through that process that the level of qualification, the capacity or the skills are capable of taking care of someone here that we believe should be the excellent care possible. So that's an important process you have to keep in mind. What does certification examinations do? What they do is, it's not an easy task. There are multiple choice questions, about 200. People sit, they go through this test for over 4 hours. We give them cases. We explain patients, this is the patient, this is what's happening, tell us what the problem is. We want to make it as patient-focused as possible. And we also ask questions about facts. There are certain facts that the physicians must know. Without knowing those facts, they are not supposed to be taking care of patients. It's not a simple thing as going back and looking at an internet or some other book. You have to know on the spot. So those are important questions that they need to know. And it is not a curve. So what we say is that if you know a certain amount of questions, we believe that you're qualified to be a physician. So that helps. And I'll tell you, we meet twice a year, and we write about 100 questions every year, new ones. And we want to make sure that they're up to date. They reflect what's going on in the medicine right now. And this is what the whole process is about. One thing I can tell you, you can feel comfortable. The first-time takers, the pass rate is about 89 to 90%, so 9 out of 10 passes. If that 10%, if they take it again, about another 6 to 8% pass. So 98% of the graduates that we have here are actually capable of passing that very tough exam. So you are being taken care of by really qualified individuals. One thing I would recommend, because I have a couple of patients do that, if you have means, go back and check the certification status at this specific website. And if the physician is not certified, ask them why. There's nothing wrong about it. There may be specific reasons. And then the last thing I want to mention is this maintenance of certification program. There's a lot of discussion going on, and I think your voice here is extremely important. We have the focus group that was extremely well attended. We have another focus group that's actually full. We were not going to be able to take more people, but the ABIM staff is here, and they're willing to and really looking forward to answering your questions if you want to talk to them subsequently. But this MOC, or maintenance of certification process, needs to be hearing from you. Because now what we're asking is, well, you finish your training, you get your certification, but 10 years later, we want you to take another exam. And the reason for that is, I will finish with this, is that medicine is extremely fast in terms of information and knowledge. It's so hard to keep up. There's so much to know. There are basic concepts of medicine one can do, but you need to be up to date. You need to be able to show that your skills are still there and you're up to date with the new knowledge that's coming on board. So it's the same thing as a plane that we wrote here, that the plane 20 years ago is not the same plane now. So you really need to have a pilot that knows what's going on to take care of you. So that's the concept that's developing. We really like to hear about that. Again, the ABIM stuff is here. If you have any questions, I'll be here after this session to answer any questions. And thank you very much for your attention.
Thank you, guys. Maggie, Dr. Klitzler, thank you very much. Great presentation. Listen, we have a few minutes for questions. So if we have any questions. Yes, sir.
My name is Lonzo Jones. I'm from Cincinnati, Ohio. I'm currently allied with the DCI organization. Now, some of the things that I heard that you presented today, and I've been doing dialysis for 24 years, I never knew that we had a support system to the higher ups. I mean, you guys is foreign language to us, as far as myself, speaking for myself. Because at the unit, it do not always seem as we have somebody looking out for us. I mean, I don't know if anybody else in here, sometimes you have to tell the nurses to change the gloves when they go from machine to machine. Sometimes the unit don't have enough nurses to actually run the unit. Somebody can call it off or something, and then, but the patient is stuck there talking about your nurses or your RNs and the doctors, okay? Who do you report that? Because the different units have different governing, you know, when you got the DCI, the Fresenius, or the Vita.
Who's going to answer that?
Who do
Well, that-
you contact when?
Maggie.
I mean, outside of that
That's what they do.
organization that's not, you know,
Yeah.
having your best interest in hand. I mean, I'm quite sure I'm not the only one that see this. I've been doing dialysis for 24 years. Sometimes the people, you know, call in and they run in the unit with 2 nurses instead of 4 or 5, and you get different information each time you ask that question.
What I can say is that the network for your area knows who you are and what's going on with you. In other words, my son currently has a bloodborne infection. You know, he's on dialysis. That's been reported to the network. The network knows that. If your unit is not meeting the clearances that they need, the network knows that, and they're going to come down on them if your unit is not meeting what it needs to meet, and they're going to retrain. They're going to institute quality programs there, and they're going to see that they are brought up to snuff where they need to be. But you, as a patient, have a right to contact the network and say, I'm noticing this. Is there something you can tell me about this? And somewhere in your unit is a network poster with the number to call. And if you can't find it, you can Google it because the information's out there everywhere. So call your network, get involved.
But I have an experience with that. You know, each network, every so often, we're supposed to have a unit check or somebody from higher up come down there. But that's like a cloak and dagger. They fix stuff up so they can come in here to look at it. But as soon as they leave, they back at their old practice.
Yeah, can I say something about that? I think you're making an excellent point. And then this is like, I always feel like the dialysis unit is like being at home or being with the family. If you've been there for 24 years, I bet you have a number of people that you interact with, the nurses and the techs and physicians that you've sort of seen more than your family members. Because it's so hard to go and tell them directly that, you know, you're doing something wrong. I think the only way to really improve what you're saying, I agree. I mean, there are different levels of mechanisms that will come from the top to tell people, but you're right. Once they're gone, are you going to be able to keep that culture of safety, culture of cleanness, you know, culture of communication in your unit? The only way you can do that is you actually need to steadily start from the tech and the nurse that you see who's doing the wrong things to be the first one to talk to. Because what happens in the dialysis units, the nurses and the techs are not used to patients talking. You know, they just sort of go there. They're so busy. Everything needs to be done. You know, we have because that's the reason why we do that is not because, you know, we benefit from it, because if you do it as standardized fashion, everything goes well. But it is the first person who does it that you have to go and tell, not the network first. Start with the person that you see who's doing it, who's not changing the gloves. Tell them so that they understand that you know. And I bet you next time when they come next to you, they will be much more careful. If that doesn't work, then you go to your nurse. If that doesn't work, then you go to your clinical manager. I bet in most units, if not all possible, but in most units, the clinical managers are walking around. They're coming and talking to you. You know, just tell them. You don't have to say, you know, you need to make that as a request as well. You can ask for your clinical administrator, facility manager to come and talk to you. That is, because if you go all the way up and ask them, that's not going to work. You have to start with the individual who's doing that mistake. They will probably respond to you more and be more attentive than responding to the network in terms of changing gloves. Because you are the one that's going to make the difference. That's what we call the patient engagement with the people that you're always interacting with. If not, you know, your biggest advocate, your physician. You have a physician that comes and sees you once a week, maybe every other week. That person should be informed, and it's that person's job to let them know.
Okay, let's get another question in. Dan, and then over here.
Okay, my question is, I like the slide
Uh-oh.
younger doctors that are more up to date and everything, they have to go back and take it every 10 years. But the older guys never take it again.
Yeah. So you're talking about this maintenance of certification process. Again, that was mandated when it came that if you are above a certain age, if you're taking your boards a certain period of time ago, that you were not required by the standards to retake it again, but the younger ones for the last 20 years. I can tell you, which I don't know, there are goods and bads in it. ABIM actually aggressively sort of recommends that they take their MOC exams as well. And believe it or not, there are a number of colleagues that I've seen who have taken it simply because they felt that it would be better for them. It's a learning process. But the other thing, which I think bad for those individuals, the number of nephrologists that have been grandfathered in are actually pretty small. They're too old to practice. And I know you're laughing, but it is true. And we've had this discussion very recently in our board meeting that maybe less than 5% or so, and they will be retired pretty soon. No worries.
Oh, I want to go here first and then you, Dave. Shanahan. Go ahead.
You said you were kind of the head, and you do make up the questions. Is this over the United States or just over Tennessee, or is it a certain area that you?
This is, the question, the board itself. So actually, I don't pick the questions, believe it or not. There's a computer ITA process that picks it. What I do, we write the questions, and there's believe it or not, there's some concept called blueprint. The blueprint is a determination of different areas of interest in kidney disease. So we cannot always ask questions about dialysis or transplant. So we make up the test based on that, and it is United States wide. And what I do as the chair is that I actually look at those questions and make sure that those questions are appropriate every time a test is prepared.
That's for a general doctor, but for a nephrologist?
That's for nephrology and also for internal medicine. We don't do internal medicine. We do only nephrology, kidney disease ones. But it's all United States wide. It's a secure exam. They take it twice a year. For the certifications, once a year, I believe. And it is administered through the computer, and it's all randomly based, 200 questions that are circulated. And we have a pool of 900 questions. So if you take the test this year, the chances of getting the same test is only 20%, because we keep the 20% that there's a consistency of questions that always come, but 80% of the questions actually changed for the next test, and then another 80% changes the next test.
Okay.
As a 70-year-old recently retired nephrologist,
There you go. I told you.
I've forgotten my question.
Yeah.
No, my question is to Maggie. As a past president of the forum, I received by email the new toolkit on the grievance process, and it's very well done. Congratulations. My question is, well, one comment. I read through it, and I didn't find any reference to facilities' internal grievance policies. Many good dialysis facilities have internal grievance policies which simplify the process for patients to get their needs met. Once the networks are involved, as you know, it becomes a very, very laborious process for everyone involved. Comment. Question is, did your group come up with an implementation plan? How can our members, AAKP members, get hold of the toolkit?
I'm glad you asked, because that is under discussion right now. We have contacted NCC. NCC is going to add it to their tools in the affinity group. CMS is very interested in getting it out there. It's being added to the NCC library. We have blasted that email out far and wide everywhere we can get, and we are looking for all and every advantage to get this toolkit into the patient's hands, because it's not going to do any good sitting out there online. We need it into the patient's hands. No, we don't have an all-encompassing plan yet. We are hoping to get more people involved in dispersing it. And we are also looking in the pretty near future of getting it translated to Spanish. That's something that we feel is very important, particularly for our southwestern states and a lot of states with a strong Hispanic population. So, yeah, you're just seeing us come with this one. I mean, It's only a newborn right now, but we're getting it out there as far and wide as we can.
Okay, we're about out of time, but let me say this. We're going to have a session this afternoon on safety and several other sessions where you will be able to get into more detail about a lot of the questions that you've asked here. Also, with respect to NCC, Jerome Bailey, who used to be with AAKP staff, has a booth here, so stop by there and maybe ask him that question about getting access to that particular tool. Listen, folks, thank you very much. You've been a very attentive audience, good questions, and remember, we're around here, so if you have some specific questions, come up and check these guys out. Thank you very much. Let's give them a big hand.